Hello friends, this is Dr. Aishwarya Kaushik, your original guru for conservative dentistry, endodontics and dental materials. This video pertains to the rapid revision of a very important topic in endodontics, that is dental traumatology. Dental traumatology from endodontics is very important. It's also important from the perspective of pediatric dentistry and of course oral surgery as well. Now guys, as you must have realized, dental traumatology has somehow become one of the favorite topics for the INI examiner, right? So erstwhile AIMS, more specifically, the trend started with in the last around 3 to 5 years back, when we had used to have separate AIMS examination. Somehow, it started with the senior residency exam, and of course, it has percolated down to the MDS entrance exam. And even now, when we see the combination of all the AIMS and PGI as well as JIPMER Pondicherry examinations, still it seems that the same trend. It's like the control of the kind of questions that are coming is coming from the central AIMS, right? If you analyze what the AIMS paper used to be and what the present day INI paper is, it seems that the same minds are making the examination. So um, keeping that in mind, this rapid revision is based on that, right? It's the traumatology is a very favorite topic of theirs, and practically in every examination they're coming with that very unique controversial questions. I'm going to start with that itself. As I always say, rapid revision, the essence or the importance of rapid revision is that these videos should be short, should be only highlighting instead of reviewing the entire topic. 90% of the things, right? Ultimately you get, you find, you realize an obstacle in those same controversial questions, right? So just before you go into the examination, 1 week, 5 days, 4 days, 3 days before the examination, my aim is that I need to slightly lay more emphasis on what is very important for the examination. And there are certain things which you've already seen, when we've been interacting in our live classes, in the app recordings, etc., etc. And of course, even if you subscribe to only the rapid revision, the idea is that you're able to solve those controversial questions, right? So with that perspective, I'm starting with the rapid revision of dental traumatology, guys. Right. Now, as I said, often repeated, so I'll star mark this question multiple times. Repeat question is that you get an X-ray, right, of an immature open apex tooth, right? Say, for example, a central or a lateral. And of course, for reference, you will be having a fully mature adjacent tooth, right? Now, they would say that, of course, the immature or the open apex, it's a permanent tooth, open apex tooth, and simply they would show you this IOPA X-ray, and then they would ask the line of treatment, right? Now, you'll have 4 options, out of which all of us are confused with whether we go for the regenerative endo or we go for apexification, isn't it, guys? You have a necrotic open apex that is immature permanent tooth, an anterior tooth, and this remains a controversial question whether we go for regenerative endo or we go for apexification. Now, the guidelines are very clear, guys. There is a classification known as Schweck's classification, right? And what is that, guys? It says that there is a type 1, type 2, type 3, type 4, and type 5 cases, right? Type 1 is that open apex case, right? In which the root length formation is the root length or the level of root formation is less than half of the final length, right? And how would you get an idea of the final length? by comparing with the adjacent tooth. And of course, if the question is framed correctly, then the adjacent tooth would be, in all likelihood, would be in a state of full maturation, right? So if it's less than half the length, that's type 1, right? Type 1 level of root end maturation. This is Schweck's classification of root end formation, right? Then we have type 2, in which again open apex with the root length equal to half of the final length, right? So I'll just write here equal to half of the final length, right? Then type 3 is again open apex with root end almost 2/3 of the final length, right? Type 4 is again open apex, but the root length has attained full final length, right? Still there's an open apex. The root end formation has not taken place. The root has not, the apical constriction has not developed, but the length of the root, the maturity of the root is pretty good, right? And type 5 is of course a fully mature, case with a proper apical constriction, right? With the proper apical constriction, and the final length is achieved, right? Now, guys, it's very simple here. In 1, 2, and 3, we are talking of wide divergent canals, also known as blunderbuss canals. You understand? Blunderbuss canals, right? So they are wide divergent canals, right? So basically what has happened is that your dentine thickness of the root canal, of the root, is very less. So you would want to do a regenerative endodontic procedure in 1, 2, and 3 for sure. So if it's 1, 2, and 3, the answer is unambiguous. Definitively, you would go for a regenerative endodontic procedure, right? Because you would want some level of root length also to form, as well as some thickness, root maturation to take place, so that the tooth is no longer susceptible to cervical root fracture. In type 4, because you have got full length, right, still of course it's open apex, so it depends on the clinician. Either you can go for a regenerative endodontic procedure or apexification. Both are equally good. You take the informed consent of the patient, tell them that for a regenerative endodontic procedure it will take a very long time. He's fine with that, go for it. Otherwise, a single MTA, these days modern day MTA and biodentine, would help you in completing the apexification procedure in about 2 or maximum 3 sittings, right? And of course, if it's a fully mature final length is achieved, then you would go for a routine endodontic intervention. So you would go for a routine root canal treatment, right, guys, as in other cases. So that's the thing. You have to see the X-ray. In your mind, you have to classify that, okay, this root seems to be pretty short, right, or just about less than half, or 2/3. Then you would go for regenerative endodontic procedure, not apexification. If it's almost full length, if you compare it with an adjacent fully mature tooth and the length is fine, perfect, you can go for an apexification or a regenerative endodontic procedure. Now again you will ask me, sir, then tell us in type 4 what is the final answer. Guys, there is no final answer. You can either go for apexification, you can go for regenerative endodontic procedure, but usually these cases, when they ask you in the examination, of course they're trying to extract or understand whether the student knows this classification or not, and usually they would fall either in 1, 2, and 3. So I would say that open apex case with a proper blunderbuss, divergent, very thin walls, proper open apex, simply go for a regenerative endodontic procedure, because in all likelihood it will be either falling in 1, 2, or 3. Even if you have some amount of confusion whether it's falling in if you feel that the root end is pretty long, the root length is pretty long, then sir, whether it's falling in 3 or 4, so there was confusion in the examination. If there was confusion, then err on the side of type 3 and therefore mark regenerative endo. Is that clear? That has to be very clear, guys. It's a very controversial question. Every year, we are facing this problem. Okay, next up, what are the other controversial things? When you talk of avulsion injury, guys, first of all, let's quickly revise the Ellis and Davies classification of trauma type 1, 2, 3, 4, 5, 6, 7, 8, and 9. So one is a simple enamel infarction, right? Or a crack in the enamel. The tooth is vital, no problem. It's an uncomplicated fracture. Type 2 is enamel as well as dentine is involved. Type 3, enamel, dentine, and pulp is involved, right? Then type 4, the tooth has become non-vital. Very commonly asked MCQ, the tooth has become non-vital. The moment they say non-vital, it's a type 4 Ellis classification. Avulsion is type 5. So remember this, avulsion is type 5. Type 6 is root fracture, guys. Again, very commonly asked these days. Type 7 is any luxation injury, right? Like concussion, subluxation, intrusion, extrusion, lateral luxation. Type 8 is fracture of the tooth en masse. What do you mean by fracture of the tooth crown en masse? That is, fracture has taken place at the level of the CEJ. So the entire anatomical crown has been separated from the anatomical root. And type 9 is a trauma to the deciduous dentition. So first of all, memorize these, right? Next important point, as I said, avulsion is falling in Ellis Davies class 5. Avulsion is class 5. Next important point, avulsion, a deciduous tooth is never re-implanted. That's of course one MCQ. Next MCQ, the best prognosis. What is the order of prognosis? The best prognosis is the extraoral dry time is less than 15 to 20 minutes, or you've dipped the tooth, right? Or the operator or the person who's suffered, the patient or the attendant has dipped the tooth in a physiological solution for up to 6 hours, right? So physiological solution, it's not like you can keep the tooth in the physiological solution for 10 days, right? So it has to be up to 6 hours. Then the prognosis is almost as good as the tooth having sustained a dry time of up to 15 to 20 minutes, right? And now, what are these physiological solutions? What is the controversy here that I want to address? There is one Hank's balanced salt solution and there is Viaspan. Now, students keep asking us before the examination, sir, which one is better? If given in the option, Viaspan is better than HBSS. In general, there's one reference, although they're both very good, right? Then next MCQ is that, sir, in the rural setting, when you don't have access to these Hank's balanced salt solution, Viaspan, which one is the best? Then it's milk, guys. Now there's also confusion regarding whether it's cold milk, warm milk, milk at what temperature. There is a lot of ambiguity there. In all likelihood, examiners should not ask you this question, right? You should never store it in normal distilled water. Otherwise cell lysis takes place. That's another MCQ that was asked recently. Then if you don't have anything, you can place it in normal saline, but that's of course after milk, Hank's balanced salt solution or Viaspan, right? But never in like distilled water, right? Never in a hypotonic solution, right? Otherwise the fluid would get inside the cells and it would burst, right, guys? So these were the important things. What are the splinting times? Next important thing, what are the splinting times, guys? So splinting times, concussion, you usually no splinting is required. For subluxation injury, about 2 weeks of physiological splinting. For extrusive luxation injury, again 2 weeks, right? For lateral luxation, guys, it's around 4 weeks, right? For intrusion, it is around 4 to 8 weeks, right? For avulsion injury, very interesting here, 1 to 2 weeks, right? But if avulsion injury is accompanied with plus alveolar fracture, then it's 4 to 8 weeks, right? Root fracture, what is the splinting time for root fracture? 2 to 4 weeks, right, guys? These are the splinting times. Memorize them. Next important question: when a tooth sustains a traumatic injury, right, what is the most common type of, if at all a resorption takes place, root resorption takes place, what is the most common type of root resorption? It is external inflammatory resorption. And avulsion is also a traumatic injury, right? It's a type of a luxation injury. So even in avulsion, right, you all know that, if you've not managed an avulsion case well, then what happens? The tooth becomes ankylosed, right? Because replacement resorption takes place, right? That is true. But it's a sequelae to external inflammatory resorption. So you understand when the MCQ comes, that what kind of root resorption is most common in avulsion injury, then the answer is still external inflammatory resorption, guys, right? So this has to take place. This takes place, right? Inflammation takes place, and then of course subsequently, again, because of various factors, if the extraoral dry time was greater than 1 hour, you did not manage it correctly, you did not scrape off the PDL, you did not treat the tooth with topical fluoride, of course ultimately and very soon the tooth's dentine, the root's dentine is going to be replaced by bone, and it's going to be ankylosed, and replacement resorption takes place. But the fact remains that initially external inflammatory resorption is the response. You understand? So here also, if for both MCQs, what kind of root resorption is most common in a traumatic dental injury? External inflammatory resorption. What kind of root resorption is most common with avulsion injury? The answer remains the same, guys, and that is external inflammatory resorption, right? So this is again a source of big source of confusion. Next important point: the problem of false negative results, right? So what happens is the tooth has sustained an injury, like a concussion injury, like a root fracture. There is trauma to the apical neurovascular bundle, right? You're doing an electric pulp test, you're trying to do a cold test. The conduction, nerve impulse conduction in your neurovascular bundle is hampered, is deranged, right? Because the nerve sustaining the trauma is stunned, right? So the action potential is not generated, it's not conducted. So when you do these tests, even if the tooth remains vital, sometimes for a prolonged period of time, the test would give you a false negative response, right? Because the tooth is vital. So it would give you a negative response, which would be ultimately diagnosed as false negative. Now, the question is, till what time can that happen, right? There is a lot of confusion in the data here. So let's just address this question once and for all. Till what time or till how much time can we, or we, the clinician, can record a false negative response to tooth vitality test. Right? Now, one statement in Cohen says that it may take up to 9 months for the coronal pulpal vasculature to come back to its normal flow, right? So Cohen says that it may take up to 9 months for coronal pulpal vasculature to come back to normalcy. So obviously, indirectly, this means that it may take up to 9 months, right? Yes, it can. But ultimately, what is going to be the answer? And for that, we follow the International Association of Dental Traumatology guidelines, which are also adapted or accepted by the WHO. And in general, irrespective whether it's a concussion injury, it's a root fracture, it's a lateral luxation, it's an intrusive luxation, the answer in those guidelines is 3 months. So that's a standard answer. And we consider this, that if this option is given, then 3 months is the answer. So I hope this question, this controversial question, is also solved once and for all. This is what I am taking as the final answer, guys. Right? So, guys, for your rapid revision, please, just before going into the examination, just quickly revise these points. And I wish you all the very best for your examinations. Thank you, guys.